welcome to the latest episode of our psoriatic arthritis podcast series alongside our RA and AXPAR podcasts. We bring you monthly slide decks to help keep you up to date with the latest research and publications in the field of PsA. My name is Peter Nash, Professor at the School of Medicine, Griffith University, and Director of the Rheumatology Research Unit on the Sunshine Coast in Australia. Fortunately, today we're being joined by Laura Coates, Associate Professor at the University of Oxford's Nuffield Department of Orthopaedics, Rheumatology and Musculoskeletal Sciences. And we also have Philip Mease, Director of Rheumatology Research at the Swedish Medical Center and Professor at the University of Washington School of Medicine in Seattle. Today's discussion will focus on two papers. The first, looking at a post-hoc analysis of PsA receiving Guselkumab, focusing on disease control across domains and patient characteristics. And the second one will be on a systematic review and meta-analysis of genetic markers and their response to biologics in inflammatory diseases. Over to you, Phil.
Thanks very much, Peter. Today's first paper is lead authored by Chris Richland and colleagues, including myself, entitled Durable Control of Psoriatic Arthritis with Guselkumab Across Domains and Patient Characteristics. This is a post-hoc analysis of a phase 3 study. So just a bit of background is that the pivotal trials for Guselkumab were the Discover 1 and 2 trials. The Discover 1 trial had a mixed population. Discover 2 were bio-naive patients. In these studies, Guselkumab demonstrated significantly greater efficacy in improving PsA signs and symptoms across the multiple domains that we will assess in psoriatic arthritis compared to placebo. And just as a reminder, the key domains that have been endorsed by GRAPPA and the GRAPPA treatment guidelines are based around these different clinical domains include peripheral arthritis or synovitis, axial disease, enthesitis, dactylitis, skin psoriasis, and nail disease. So we're focusing now on Discover 2, the bio-naive population, slightly larger of the two trials. And we're looking at really high thresholds of disease response, the more stringent ways of evaluating response in subgroups of PsA patients further defined by their baseline clinical characteristics. So there were a total of 739 patients in this analysis, and they were either treated with Guselkumab 100 milligrams every 4 weeks on an ongoing basis, 100 milligrams every 4 weeks initially and at week 4, and then every 8 weeks thereafter, which is the approved dosing regimen, or versus placebo out to week 24, followed by Guselkumab 100 milligrams every 4 weeks. The thresholds that we're looking at are ACR 50 and 70. Remember, the primary endpoint was ACR 20, but we're looking at higher thresholds of joint response. The independent global assessor of psoriasis being 0, or complete response in the skin. Resolution, complete resolution of dactylitis and enthesitis. Achieving the MCID of the FACIT score, which is a measure of fatigue, the MCID of the HAQ score, which is a measure of function, achievement of PsA, which is a composite measure, low disease activity, and then minimal disease activity, which is a composite criteria originally developed by Laura Coates, who's with us today, and developed a number of years ago and has now become a really important target of treatment in psoriatic arthritis. And then the subgroups that were looked at were looking at response based on sex, baseline medication use, BMI, psoriatic arthritis duration, swollen or tender joints, CRP, and psoriasis severity and extent. So looking at all of these factors at baseline and then seeing if they influenced the achievement of these high thresholds. So we saw that in the results, the baseline clinical characteristics were pretty well balanced between the three different treatment groups. There were slightly more males in the Q4 and Q8 week groups of Guselkumab than placebo, but otherwise well balanced. And then a pattern of continuous improvement through week 100 by NRI analysis was observed across key PsA domains and patient-reported outcomes. So 44 to 75% achieved an ACR 50 response, 23 to 45% achieved an ACR 70 response, 65 to 85% of patients had complete resolution of enthesitis and dactylitis. 50 to 70% achieved complete skin clearance. This is not too surprising given what we know about interleukin-23 inhibition in the skin being quite powerful. 60 to 80% reported meaningful or MCID improvements in function as measured by the HAQ and fatigue as measured by FACIT. 40 to 65% achieved the PsA low disease activity threshold, and 35 to 50% achieved minimal disease activity criteria. So in conclusion, we can see that patients with active PsA entering the phase 3 Guselkumab trial had durable, out to 100 weeks, achievement of these stringent endpoints associated with disease control across the key psoriatic arthritis domains and patient-reported outcomes. So these endpoints were achieved regardless of male-female status, BMI, disease activity, or use of concomitant CSDMARDs such as methotrexate.
Why don't we discuss it for a sec, Phil? And I'll ask Laura, first of all, the domain approach of GRAPPA and composite indices. Any comments? Now that we've got drugs that are great for one domain and maybe not so great for another, is there an argument for having a domain focus rather than composite disease measures, or do you still think we must use composites?
So I think both are helpful. We want to know if we can control disease overall. So getting to states like minimal disease activity is important because it's good for patients. We're looking ideally to control disease across multiple domains. But there is obviously a benefit to looking at individual different domains, as has been done here, to help you understand which drug is working in which domain to which degree, because that's a lot of how we personalize our therapy. So it's still useful to look at skin responses, for example, or axial responses, or dactylitis or enthesitis, because then that will help us understand how the drugs compare and where the sort of subtle differences are. But I think there's an advantage to having the kind of overall disease control metrics as well.
Super. So Phil, were you surprised that gender didn't seem to make a big difference in this particular study, or even BMI?
In relation to sex, I would say yes, partly because of the emerging data that suggests that females don't respond quite as well to treatments, biologic treatment than males. And so I was a little bit surprised in that regard. BMI, possibly not so much, because although we've seen in some studies that heavier patients don't respond quite as well, I would say in the majority of patients with various mechanisms, they do well regardless of weight. So I do think that this is an important lesson.
Thanks. I just wonder if we need to change doses in people over a certain weight or increase frequency. Laura, being effective without methotrexate is a big plus.
Yeah, definitely. So a lot of patients don't like taking methotrexate. I think in pretty much all of the post hoc analyses of the biologic trials, you tend to see that the endpoints are achieved regardless or not of whether people are on methotrexate. And I think there isn't hugely strong data for methotrexate boosting efficacy of the drug in the same way that it would in patients with rheumatoid arthritis with other biologics. But I think there's still this question about longevity. Obviously, we've got data for TNF inhibitors that being on a bit of methotrexate alongside your TNF inhibitor makes a difference, but we don't really have data for any of the other mode of action about whether it does impact long-term outcome. And it'll be useful to see more of that from registry data as we get a bit more real-world data with the IL-23s.
And on that point, Philip, where do the 23s fit into the treatment algorithm in the US? Is it domains approach? You pick the domain that the 23s are the most effective for, or where do they sit given their very strong safety profile?
Well, where we would sometimes like to position them as very early in use, because we've seen that there's better efficacy if you use the IL-23s like other medicines in early in the disease process. And the safety profile, when we get done speaking with patients about the safety, they say, "Wow, this sounds great. I would endorse going on that medication." But then we have to deal with formulary managers who often will say, "Nope, you've got to step through a biosimilar adalimumab, for example." And I know that's true in the UK as well. And so we have a little bit of a struggle there sometimes. But if a person has a contraindication to using a TNF inhibitor, for example, then we are free to choose amongst the various mechanisms, and partly because of safety, but also overall efficacy, and especially in the skin, we would favor an IL-23 inhibitor. Interestingly, we're finding more and more dermatologists reaching right for an IL-23 inhibitor as their first agent for treating psoriasis. And so sometimes patients come to us already on one of the IL-23s.
So, Laurie, you gave a lovely presentation at the IFBA meeting in Stockholm, preventing PsO becoming PsA. And there's just been a couple of clues that 23 inhibition might be superior to other biologics at that, preventing that. The Singlar paper, the TriNex paper that was presented at EULAR. What's your feeling about that? Do you think the studies were soft and we need to get more data, or do you think it might be a signal that 23 early does have an advantage?
I think we need more data. I think we read too much into observational data like that with a lot of confounding within it at our peril, and over-interpreting it, I think, is risky. We've seen this looking at systemic drugs versus phototherapy or topical drugs and the different biologics compared to each other. But there are so many different reasons, as Phil's just mentioned, why we pick certain drugs. And I think, IL-23s have historically very much been seen as a dermatology drug. They're for patients with bad skin. They're typically not used first line in psoriatic arthritis most commonly. And so the patients going on to IL-23s may well have a lower risk of developing PsA anyway. And obviously the big question is not just whether it treats or hides or masks psoriatic arthritis while you're on the biologic, but what that does to you in the long term. So if you would have developed PsA, you're on a biologic that clearly treats psoriatic arthritis, as most of our psoriasis drugs do, and that is about to happen. It may prevent the psoriatic arthritis showing itself, but is that just controlling things while you're on the drug, and the minute you stop the drug, the arthritis will then pop up? And does that change the long-term outcome? So does having a biologic on board early make your disease more amenable to treatment, milder? The fact that you've treated earlier maybe gives you a better outcome? Or actually, if you're developing psoriatic arthritis on a biologic, does that suggest that your disease could be more resistant? So I think there's still a lot of questions about what the long-term outcome from any of these early intervention studies will be. And we do have some studies recruiting. There are two looking at using Guselkumab in slightly different populations about how exactly we define early or pre-PsA and with slightly different approaches. But it's very, very difficult to do the studies with the biologics because you either treat somebody with mild psoriasis and compare to a control like a topical therapy, but that means giving somebody a biologic that they don't have an indication for, or you treat patients with moderate to severe psoriasis, but it's very hard to have a control group where you don't treat them because it would be unethical to not give them an effective therapy. So these are not simple and straightforward studies to do, and I think there's a lot we need to sort out and design those very well to get concrete answers about how best to intervene.
Thanks very much. So shall we move on to the second paper, please, Laura?
Sure. So paper 2 is a paper by Al-Sofi et al. Entitled The Association Between Genetics and Response to Treatment with Biologics in Patients with Psoriasis, Psoriatic Arthritis, Rheumatoid Arthritis, and Inflammatory Bowel Disease. And as you mentioned, this is a systematic review and a meta-analysis. So obviously we know that across all these different diseases, biologics have really revolutionized how we treat chronic inflammatory diseases, but they don't work for everybody. There's still a proportion of patients who don't respond to biologics in a primary or secondary non-response and need to switch to a different treatment approach. So if we could work out a good way of predicting who will respond to each drug or each mode of action drugs, then we could potentially try and approach this in a precision medicine way. That would make a big difference to treatment failure for patients who often try medications for a number of months to see if they're going to be effective. And obviously it would reduce costs as well if we were eliminating drugs that were likely to be inappropriate for a particular patient. So this study looked at all the evidence out there about genetic markers and how they can be used to predict response to biologics across chronic inflammatory diseases, and also kind of individually within the disease, because it may be that these different markers are more specific or helpful in one disease rather than another. So as you'd hope for a study that's doing a systematic review like this, it was following the PsMA guidelines and the PsMA statement. They identified quite a high number of potential records through the database search, but excluded quite a lot, as we often do in systematic reviews based on title and abstract. So they ended up with around 300 reports that they wanted to review. They assessed the full text of just short of 300 that they could get hold of and excluded a further 100. So this SLR actually includes 185 different studies with over 60,000 patients. So it's a very large meta-analysis looking at this data. So when they looked at genetic SNPs and the response to biologics across all types of chronic inflammatory diseases, so pooling them together, they found a few key markers that seem to predict response to TNF. So MYD88 associated with a good response to TNF, NLRP3 and TNF238 associated with a poorer response to TNF, and then some markers that seem to be associated specifically with infliximab response. And then they looked individually in the different diseases. So in psoriasis, they found particular SNPs associated with, again, response to TNF, either a good response or a poor response, and showing quite strong associations for some of the SNPs. For psoriatic arthritis and rheumatoid arthritis, a little bit different. But again, different SNPs, but all around response to TNF. And I guess because that's where the majority of the data is and the majority of the patients have received these drugs over the last few decades. They've also picked out SNPs for patients with inflammatory bowel disease. So in the gastroenterology literature, and identified some different SNPs that were associated with good response or poor response. So really showing that actually it's not the same across diseases. There are some that seem to be similar, but some that are specific in particular inflammatory diseases. So there are some genetic variants in TNF alpha and NLRP3, MYD88 and FcR gamma genes, which were associated with a response to TNF across different diseases. And then in particular disease areas, there were different genetic variants that seemed to predict response, specifically in psoriasis, in rheumatoid or IBD. But obviously what we really need is something that will work at an individual level, not at a group level, but actually, is there anything that can really predict whether an individual patient is likely to respond? And none of the individual SNPs alone were able to do that. It may be that we could think about a panel of SNPs or combining kind of genetic SNP data with other omic data to think about predictors of response. But that's kind of our holy grail that we're searching for in precision medicine, is something that we could apply to an individual patient in clinic and say, because of this test, we know that the drug for you is a TNF inhibitor or an IL-17 inhibitor or whatever.
Thank you very much, Philip. Do you want to comment? What are we to make of these kinds of genetic studies and just scratching the surface of trying to find a precision medicine type approach? What do you think?
I think it's coming. This isn't it, because of the fact that first of all, this is going to be a little bit hard to apply commercially. Second, because it's not quite as specific as we need. But already we have some of these biomarker guidances in practice. For example, there's the so-called PRISM assay that we use in the US, and which can help sort through whether or not a patient is likely to respond to a TNF inhibitor or not. And I've used this on several occasions when the patient is supposed to not be very responsive to a TNF inhibitor. I've used it to help leapfrog over a required step of using a TNF as the first line agent and going on to a different mechanism. The other assay that we're using to a certain extent is the so-called vector assay, which tells us something about rheumatoid disease severity. And that has been a helpful biomarker composite assay for us. So I think that this is coming. This isn't quite it, but it's if this can be moved toward something that's practical, reproducible, and commercializable, then I think this is important for us in the future.
Yeah, just scratching the surface, so the TNF variants, the inflammasome variants, MYD88 is innate immunity. I don't know what FcR gamma genes are going to control. Laura, any relevance to your to practicing clinicians in the UK, or is it all just too early and the signal isn't strong enough for any particular intervention?
Yeah, I think it is, as Philip's alluded to, it is too early in terms of making this work, but there is momentum in this area. There's been so much work looking at precision medicine, trying to find markers of response. And we have got some studies suggesting in rheumatology that we can find usually a panel of markers, not one magic test, which is the predictor of all things, but a panel of different markers that you need to look at that could put somebody in a high or a low risk group. And I think that's probably the thing that's going to be most useful. But obviously, it's likely to be different as this shows across different diseases. So we can't just borrow from rheumatoid or from IBD or from psoriasis. And it's highly likely, given how much our immune system changes and evolves through treatment and through the disease course, that it's going to be very specific to time points as well. So what works in predicting response to your first biologic may not work at all if you've previously failed a TNF but have been experienced in having a TNF inhibitor and have had changes to your immunology because of those previous medications. So I think it's going to be hard to find the one test. It's going to be much more likely to find specific tests for diseases and specific time points in treatment courses that might be able to make this a reality in the clinic.
So fascinating, but a little bit early. So thank you everyone for joining us for this PsA podcast brought to you by the Immune-Mediated Inflammatory Disease Forum. Really hope you've enjoyed and found it useful. If you did, don't forget to subscribe to our channels on YouTube, Spotify, SoundCloud, or wherever you get your podcasts so that you don't miss any future episodes. If you want to read more about what we've discussed today, you can visit the imidforum.com, where you'll find detailed summary slides for today's publications. Thank you so much, Laura and Philip, and we look forward to talking to you next time.